Good afternoon, everyone. Thank you for joining.
Hi, I'm Dr. Horn.
I'm Dr. V. We wanted to talk about infectious diarrhea and testing and treatment today. We haven't covered this, I think, in a long time, so we thought it would be good to chat.
Yeah, this is one we don't talk about very often,
Yeah.
but I think it's a good one to cover because we do get a lot of questions about this. It's about, infectious diarrhea, which I don't know that we've talked about that too much.
I think we've talked about C. diff a lot, but not
Oh,
so much the other stuff. So I think this will be a good review. And we'll go over some like how we used to test versus how we have new testing modalities too. So starting on the next slide, I just wanted to give just an overview of global burden of diarrheal illness. It's pretty sad, especially worldwide. I think of like when kiddos die, unfortunately, around globally. I thought it was other reasons, but one of the still big reasons for children death in globally is diarrheal illness, which kind of makes sense. And they divide it by different burden of infection, and diarrhea is about 11% globally. So thankfully, we don't see it as much in US.
no,
Excuse me. Thank you. But it's still a big issue globally. And globally, one of the big things that they struggle with, safe water, hand hygiene, because they don't have clean water to do hand hygiene, vaccination. We are much better, but we still struggle here. So next slide. So this is a really nice slide that kind of talks about how much burden and economically how much money that we use for diarrheal illness.
so globally, like you said, it's a huge problem, and
Yeah.
in the United States, it's a big problem as well. It's they estimate 48 million U.S. cases, and this is acute gastroenteritis. So it costs a lot of money, but it's a major public health issue, and we'll talk about, some of the testing and its relationship to outbreaks and why it's important to diagnose it quickly and get it under control. But, it's a variety of pathogens in water and food, and just as you're saying, it's the food and clean water, clean food, and
Yeah.
hand washing. And hand washing seems, we've heard this all of our lives about it's very important to wash your hands, but it's true. It can save a
Yeah.
lot of, infections and from spreading.
Even, I know like we don't think about salmonella or shigella, those type of
Mhm.
but we still see it in the infectious disease world. I take care of patients in the clinic and in hospital, they get admitted with some bacterial diarrheal illnesses too. So it's kind of important to think about. A lot of times, sometimes my patients that have like salmonella and things like that are sometimes, our members who live in farming area,
Mm.
farmers and community members in the farming area because there's a lot of exposure to animals as well. So I think that's another risk factor, not just food and water, but animal exposures as well. And in US too, when there's like change in air, water, temperature, precipitation pattern, water, stagnant, there's a lot of relationship to bacterial infection and viral infection too. And most of the time, children are really affected, young children, because they get dehydrated really quickly. Not only do they get sick, but dehydrated with the viral illnesses and bacterial illnesses. And of course, elderly and immunocompromised patients. So 2017, Infectious Disease Society of America updated their practice guidelines for diagnosis and management of infectious disease diarrhea. So, we always talk about guidelines updated, and this was one of the guidelines that was updated in 2017. So I want to kind of review some of the data in here. So how they define diarrhea is that acute diarrhea, they say 0 to 13 days. Persistent diarrhea is when they say is like it's 2 weeks and you're still having diarrhea more than 3 episodes a day, watery diarrhea. And then chronic diarrhea, they define it as more than 30 days. And we do have a lot of patients that fall into this category, but we're going to be focusing a lot on the acute because of the bacterial and viral things that happen really quickly. So we'll focus a lot on that. But chronic diarrhea, we get into like inflammatory bowel disease or, irritable bowel disease. So those Crohn's, ulcerative colitis, but we're going to focus more on the acute bacterial and viral.
Yeah, and when it comes to etiology, usually infectious disease, we think of acute.
Yeah.
Because if it's been going on for like weeks or months or years, usually not infectious. There are some exceptions, but in general, when we're talking about infectious diarrhea, we're talking about acute, within under 2 weeks.
And then I like this like picture diagram, they say animal exposure, like I was talking about, if you have animal exposure, think about diarrheal illness. A lot of times, like if you have like pets, like turtles and, snakes, and they could get like salmonella poisoning that way. So like really important, like when we have patients kind of get animal exposure, sometimes sexual practices, hospitalizations like C. diff, long-term care facility like C. diff. Childcare is notorious. My kids used to have so many different diarrheal illness, so that's important to know. A lot of time viruses, foodborne illnesses, international travel. Dr. Hone and I we work in a travel clinic. We actually advise patients when you travel to a lot of countries how to be safe. What do you usually tell your patients?
Yeah, we usually give them a packet on, bottled water and to eat things that are peeled and, if possible, avoid things that are not cooked like ceviche. I made that mistake when I was very young and I went to Mexico. Ceviche or salads, things like that that you're not as sure that where it came from or how it was prepared, things like that. Yeah, and we talk mainly about infectious diarrhea and is it an infection or not an infection? And when people travel, we discuss the vaccines and being up to date on typhoid vaccine and hepatitis A. And so it's vaccines and what you can do to prepare, and then what you eat and where you're going.
And one of the big thing I always tell them is when you're traveling in our travel clinic is don't eat street food and eat well-cooked food, bottle water, wash your hands, and like you said, don't eat uncooked food or salads and things like that. Depends on where you're going. And I really like the CDC website where you could type in CDC travel India, CDC travel Mexico, and then they'll tell you what kind of infections to look out for too. So I tend to do that for my patients. Do you use that too?
Yes, I do. Because then they can read about it themselves and they can see where to get the information. And traveler's diarrhea usually goes away on its own. So we give people Imodium to take with them. So they're not, looking for a pharmacy for Imodium in a foreign country while they're having diarrhea. So they'll bring Imodium with them, and usually it goes away on their own. So if they're just having straight diarrhea, it's usually just lasts a few days. But if they're feeling bad, so if they are having a fever or abdominal pain or blood or pus in the stools, or I say just not feeling well, like you feel like you're really sick, then we also give them usually azithromycin to take with them. So start with Imodium and Gatorade or water, something to stay hydrated. But if you have any of those warning signs, then take the antibiotic. And if you're not better, then you need to see a doctor in that country.
Yeah.
And then as far as infectious causes of diarrhea, so there's usually it's bacteria, viruses, and parasites. And from here on out, we're going to be talking about the United States and not other places or travel. But, these are some of the common causes of infectious diarrhea. So Campylobacter, C. diff, Salmonella, Shigella, Vibrio, Yersinia, or viruses like norovirus is a big one. Rotavirus is also one that we see rather frequently, and usually it's older adults or children. But there's a new vaccine that just came out.
They have they've had a vaccine for rotavirus for a long time, but now there's a newer version of that too. And then I know having the rotavirus, I was reading that vaccine has helped decrease the hospitalizations for kids. So kids, that's huge.
That's big.
Yeah. So that's been really good.
And then parasites, Giardia, Entamoeba histolytica, Cryptosporidium. These are some of the common ones that we see.
So in this chart now that, there's lots of different diarrheas. Now we kind of talked about bacteria, parasite, viruses, right? So they want us to kind of think about when we have diarrheal illnesses, how does our colon feel like? Inflammatory versus non-inflammatory. So they say usually if it's non-inflammatory, like not usually it's like viral, but can sometimes be bacterial or parasitic. Um, Physiology for non-inflammatory is most likely intestinal secretion without significant disruption in the mucosa of the colon. So you're not getting blood and stuff most of the time. Usually, if you have like non-inflammatory viral, for example, you have nausea, vomiting, can have abdominal cramping, but non-bloody stools, watery, non-bloody. You might have not really have a lot of white cells in the stools if you test for that. And here are some of the examples. Some of the bacteria can cause non-inflammatory, including rotavirus and norovirus. But Cryptosporidium is a parasite. Vibrio, C. diff, E. coli sometimes can also cause non-inflammatory. But inflammatory diarrhea is when your mucosa of the colon is really disrupted and it's inflamed and hurt and friable. That's when you have really bad pain. When you're going to have a bowel movement, spasms, and it's really hard to have bowel movements, bloody stools, and you have lots of white cells in your stool too. And those are associated mainly with a lot of bacterial like Salmonella, Shigella, Campylobacter, E. coli that produces Shiga toxin. I'm sure you all heard about the E. coli 0187, and then Clostridium difficile sometimes can do that too. And then Entamoeba histolytica and Yersinia. So some can cause bloody inflammatory diarrhea and some can be non-inflammatory but still diarrhea, no blood. Here again, that's what they go over here. Bloody stool, if you have in a patient, we always think about in the hospital C. diff, but you always have to think about the other bacteria that is associated. Shigella, E. coli 015787, Salmonella, Campylobacter, Yersinia, and then of course Entamoeba histolytica. Entamoeba histolytica is usually when people drink, they go camping, river water exposure. So think of those type of things as well. But this is for bloody diarrhea.
And then diarrhea with fever, sometimes when you think about bloody diarrhea, I associate that with invasive, that the bacteria is invasive, and the ones that are known for being invasive, Salmonella, Campylobacter, Shigella, enteric viruses. This is norovirus, rotavirus, adenovirus, and then cytotoxic organisms like C. diff and Entamoeba. And so, there are different ways to organize your thoughts about when you see a patient with diarrhea, how to kind of think about it.
And then here are some organisms that can cause really bad abdominal pain too. The important thing, this is kind of cool, Yersinia enterocolitis. So just for our ID doctors, we like this, is that it can mimic appendicitis. So you could have right-sided abdominal pain where like you think it's like a mimicker for appendicitis, but it's actually it's due to Yersinia infection. So something for all of us to think about. And Vibrio, this happens a lot and it's non-cholera, it's just Vibrio. And this happens a lot in coastal regions, right? Seafood. So, if patients are in saltwater area and things, they are exposed to Vibrio, especially patients who are like diabetic, liver disease. If you especially have cirrhosis and liver disease, they're really high risk for Vibrio infection if they go into like seawater. We don't see a lot of cases where we live, but we do I have seen a couple of cases where I've had like patients travel to a coastal area like Florida and they come back really sick and then they end up having Vibrio. Also, you could get Vibrio infection, Nifficus infection, for example, if you're eating like raw oysters and stuff too, and if you have like liver disease. So think about seafood and Vibrio and salt water, seawater is what I think about when it comes to that.
And then vomiting and non-bloody diarrhea for 2 to 3 days of norovirus. So when I hear vomiting and diarrhea, the first thing I think of is norovirus. Yes. Is that what you think of? So norovirus is the first thing, and part of it is because it's so contagious, and so and cruise ships is a big one, and that cruise ships it's because the people are all contained and they're also close, and it's so contagious. So if someone vomits and somebody walks by the vomit and just walking by the vomit, it can be up in the air and it's kind of all over, and then walking by it, it kind of coats you, right?
Yeah.
There's kind of a cloud of norovirus. So I think they say within about 15 feet or so of the vomit that you're at risk of getting it. And there are famous cases where, someone vomited in a bathroom and then everyone that went in that bathroom came down with it. And so when they do outbreak investigations, they can say, oh, everyone went into that bathroom. So norovirus spreads so easily that it's a big issue in hospitals trying to contain it.
Yeah. So for me, I do a lot of infection prevention work. If I see a patient or the concern for norovirus who have, it's really important to do like modified contact because norovirus is not easily killed with soap and water. Sorry, with alcohol. So you have to wash it off just like C. diff. So hand washing with soap and water. Also mask and eye protection, just like you were saying, when they throw up, vomit, there's so much particles that you could inhale and get sick, or you land in your eyes and you you touch everywhere and you could get it, and it's very contagious. This is one of the big reasons in cruise ships and stuff, they have huge outbreak. I remember during there's always a cruise ship outbreak case with norovirus. So just good hand hygiene, and then it's usually self-limiting for the most part.
Mhm.
So diagnostic testing, right? So diarrhea, how do you diagnose what bacteria? So I would say when I was in training, we didn't have all the fancy tests. So, you had to like, if you think you order stool culture, and then, it takes so long for our like microbiologists to figure it out.
Yeah.
But in our guidelines, they say diagnostic testing is not routinely recommended, like you were saying earlier, with uncomplicated travelers diarrhea unless treatment is needed. However, those with diarrhea lasting 14 days or more should test it for intestinal parasite, and those were treated with antimicrobial with the preceding 12 weeks should consider C. diff testing. So, if they're persistent diarrhea not getting better, we should consider testing. Gastrointestinal tract disease, inflammatory bowel disease, and things can happen too. But what used to happen is, when we got really bad diarrheal illnesses, we'll order a stool test. It'll take days and days and days to like isolate.
Yeah.
And they really had a hard time. There's so much bacteria in our stool for us to figure out which one is really causing the infection, and patient is getting worse. So this was a really big struggle for us before. But go ahead.
Yeah, and if it's been acute and short term, I thought you were going to say patient's better by the time
Yeah,
it comes back.
that too, yeah.
Sometimes the patient's better, and then you'll get the result and you'll say, oh, I don't know if this needs treatment. And then you'll see the patient if they're in the hospital or call them on the phone and they'll say, oh, I'm better. And so you're able to identify it, but the patient's already improved. But the flip side is that they could be getting worse and then you've lost all those days. So you're either empirically treating them, or if they're not doing too badly, sometimes not giving them anything and waiting to see, what the results are, especially if you think it might be something like C. diff, because if you give antibiotics that if for C. diff, it might get worse.
And I talked to a microbiology director, and he always says stool culture is so cumbersome for the microbiology techs. It takes hours and hours. They have to figure it out, then isolate each organism. And it's so much manpower and material. And by the time they get to his patient is better or they discharge.
Yeah.
So diagnostic, next slide.
Oh, so who needs testing? So we're saying, there are some times where it's not too helpful, but there are some times where it can be very helpful. And acute gastroenteritis cases, so usually self-limited, but in certain populations like immunocompromised hosts, so those may be transplant patients, those may be
chemotherapy,
right.
Cancer, or patients on like those monoclonal, the mAbs,
Yeah, and so immunocompromised or critically ill. So critically ill patients, they need to figure out things right away. And those with prolonged disease refractory to treatment. So those are like you were saying, if it keeps going on for a long time, then finding an answer is very important. And sequelae could include Guillain-Barré syndrome, reactive so people that acute gastroenteritis. They may get acute gastritis, and even if they get over it, they can have things lasting a long time, like Guillain-Barré, reactive arthritis, irritable bowel, malabsorption, or hemolytic uremic syndrome. So things can continue.
Yeah. So like, just like what Dr. Hahn was saying, it's interesting. We just think about diarrheal illness just causing just diarrhea, but it can cause other systemic symptoms too. So erythema nodosum, it's when you have these inflammation nodules all around, red, painful nodule. And that can happen because of some of these bacterial diarrheal illness. You know, there are other autoimmune disease, or pregnancy can sometimes do it too. But diarrheal illness can cause the skin lesions all over. And of course, Shigella, Campylobacter Yersinia can cause kidney glomerulonephritis. Guillain-Barré, do you want to talk a little bit about when it comes to Campylobacter?
So people will get Campylobacter, and then they may get over it, and then but they'll get Guillain-Barré. And so Guillain-Barré can essentially they can become slowly paralyzed, and they get can it moves up, from their feet, and it keeps coming up, and then it can come up for a while, and then hopefully it goes down and resolves, but it can come up and it can affect the lungs also. And then if it affects your lungs, then sometimes they'll need to get intubated, and it can be really bad.
I think a lot of people, when they hear Guillain-Barré, they associate it with vaccines a
Vaccines,
lot,
yeah.
but I don't think a lot of people know that it can be caused by diarrheal illnesses too. And Campylobacter is a big culprit, I believe, for that.
Yeah, I think it's the number one infectious cause.
Yeah.
Yeah.
And then hemolytic anemia can happen with, again, Campylobacter and Yersinia. So if you have diarrhea, that could happen too. And of course, hemolytic uremic syndrome. That we learn a lot about, HUS and how you could get that, but really not supposed to give antibiotic because it's supposed to make it worse, especially in kids.
Yeah, especially in kids. And so, we were talking about travel earlier. So if a person, like an adult, gets traveler's diarrhea and it doesn't go away, we give them an antibiotic to take with them. But with children, we don't give antibiotics for the children if the children get diarrhea, because just for this reason, for the concern over HUS, and so getting worsening with antibiotics. So the children, we recommend seeing a pediatrician and seeing someone in that country where they are.
HUS is a complicated syndrome to treat. You might need steroids. Sometimes it can affect so many different organs. Like you might need plasmapheresis. So depends on how bad it is. So it's really important, if you have the Shiga toxin or Shiga producing bacteria, not to give antibiotics to patient.
And it's tough because we're giving the parents antibiotics, and then we're saying if your kid gets sick, don't give them your antibiotics. Yeah. And then reactive arthritis.
Yep. Reactive arthritis, with these diarrheal illness, you could get arthritis. It's usually multiple joints at the time, swelling, pain. I haven't seen as much of this, but in the past, a little bit. Have you seen any recently? Or?
I don't think I see this very often, and it's usually after the infection is already kind of going away or resolving. So I think, if it's something that happens after they have the infection, I'm sure I've had patients that have gotten it, but I'm usually not told. I'm usually not contacted.
Usually these patients are seen by rheumatologists. They might need anti-inflammatory medication, but it can't last on for a while. Meningitis is one thing, Listeria and Salmonella. Salmonella can cause meningitis in young babies, but also in immunosuppressed and other people too, especially Salmonella typhi. But Listeria, of course, you all know, can cause meningitis. It's one of the big things that anybody that comes in with the hospital, if you worry about meningitis, we always cover for if you're less than 1 month old, older than 50, if you are pregnant, immunocompromised, we always give Listeria coverage because usually they get it from like processed meat or unpasteurized milk or dairy products. So we always tell our pregnant moms and things to be careful. And this infection is very important when you think about meningitis, just to consider Listeria as well. And treatment, right? So a lot of times people ask, okay, so now I have these different types of infections. So I have, for example, well, we all talked about C. diff before, so we know oral vancomycin fidaxomicin is C. diff treatment. But if you have Campylobacter, like you were saying, azithromycin, I tend to go away from levo whenever I can, fluoroquinolone. So azithromycin is a great antimicrobials if needed. Non-typhoid salmonella, usually not indicated, but uncomplicated. But complicated, I tend to use cephalosporins. What have you used for complicated?
Cephalosporins, yeah, like ceftriaxone
Yes.
is one that I would prefer. Yeah.
So, oh, it's right there. Yeah. Salmonella typhi, you could, so cephalosporins are okay. And also you could use fluoroquinolone or azithromycin again. And then Vibrio, this is when you get diarrhea after eating like raw seafood or if you're around seawater, high risk for liver disease patients. And for that, doxycycline is a drug of choice, Vibrio cholerae, and also non-Vibrio as well. And then parasite, cryptosporidium. So this is kind of important to know. I see this often here, especially in like our HIV population, but I also seen it in non-HIV population. I have used nitrous oxide. It's kind of expensive now. Have you used a nitrous oxide in non-HIV patients?
Yes, and it's, usually when we get it, we see how bad is the patient doing, because some of them recover on their own, but I prefer to treat,
Yes.
especially in the elderly, especially, if I'm worried that they've had it for a while, because sometimes they'll get it and it seems like it persists for a long time and until they get treated. Sometimes it seems
Yeah.
like, or at least, when I see them, it seems like it's been going on a long time. So, but I would prefer to treat, because nitrous oxide is actually well tolerated. People do well on it.
Yeah, they do well, and it's a short course, depending on the 3 to 7 days. In immunocompromised, you might have to do it for a longer period. Yeah, people tolerate it, and otherwise they have really profuse watery diarrhea, and it's really bad. So I tend to treat it too. Other infections, I don't know how often you all will see it. If you see Giardia, again, travelers and such, river water, well, flagell is one of the big things that we use.
And then as far as diagnosis, so like you were saying, the traditionally it takes a long time to identify something. And so because it can take so long and nobody likes working with stool, there are some things that have come along that have made things a lot easier, that we can identify them a lot faster. So in the past, the drawbacks, it was time consuming, labor intensive, operator dependent, often involves test selection based on clinically indistinguishable illness. So,
diarrhea is diarrhea.
yeah,
It's so hard to say what causing it.
Right. So like, what are they looking for? And then if they find something, is it important? Turnaround times of several days was the norm. And it still is for, for most methods. Now, you also have PCR.
And this is from the company called BioFire. No compensation, no conflict of
Yeah.
interest. I just got it from their website, but it was really, they had data to show it. And what they were showing is now like the PCR, if you give them a stool, and this is kind of what we experienced too, you get data back in 1 hour versus traditional, it took 48 to 96 hours. So a long time. PCR yield, how many times you're able to identify it is about almost 50%. Traditional, those stool culturing techs used to do only like 16%. So PCR, they could like probe a lot of bacteria and parasite and viruses. So they could look for like 22, for example, in this company. At one stool, one specimen, they look for 22 organisms. But if you're doing stool, you're just doing one pathogen at a time. So, this is their claim to fame, is that they reduce average length of stay by 12 hours, prescribe for antibiotics, and ascribing for fewer antibiotics and fewer antibiotics, and lower duration. Again, no financial conflict of interest, but this was just getting it from their site. This is interesting to compare PCR versus traditional.
Yeah, there are different multiplex PCR, devices, but we're going to talk about BioFire because that's what we use.
Yeah.
So we're not compensated, we don't have stock, we don't get money, we're not reps. But this is what we use.
Yeah.
And so this is, when we talk about multiplex PCR, that's what we're going to be talking about mainly about BioFire is what their trade name, but it's a multiplex pathogen panel. And there are different ones that use blood or there's a respiratory one, there's a CSF one for meningitis, but the stool one, you essentially use stool, and then it gives you a lot of information, which we'll talk about. So the benefits of this is a reduced sample volume, so you just use a little bit of stool, broad coverage without the need to select specific tests. So it will test a lot of things, and the most important thing is having the common things on there, because that's what you're going to see the most, but it covers a lot of things. And then the sensitivity is very good. You could do a lot of stool tests and faster turnaround time, like you were saying. And diarrheal diseases, by definition, have a broad range of potential pathogens, and it's well suited for this type of testing. So you're just taking a little bit of stool and you're checking for a lot of things. And then these are the most common, and these are the FDA approved tests. There's a Luminex, a BioFire, and a Verigene, and that's why we said we're not paid by BioFire, but that's the one we're going to talk about most. Is just this is the one we're familiar with.
Yeah, but all of them have certain amount of targets.
Yep.
So once you have a target set in the PCR, you put in the sample, and the PCR probe is just probing for these targets. And so some of them have 14 pathogen, some has 9 pathogen, BioFire has 22 pathogen. So like you're just probing for everything. And there is some dissent. I'll talk about a little bit about some of the down things to this too.
Oh, and so this is what I was saying about the BioFire. There's a respiratory, a blood culture, and a pneumonia, a GI pathogen, and meningitis. Now, with a blood culture, you have to have a positive culture, and then you put it in the machine. Where with the others, like GI, you can just use stool. With joint and fluid, you just use the fluid in the joint, and CSF, the same thing. You just put the CSF in, and then it will give you a report. But the blood culture, you have to have a positive test. And what does it look for? We'll show what we're looking for in the GI pathogen panel, but it's looking for viruses, bacteria, parasites, yeast, and then also antibiotic resistance genes. So it may say, like, for example, in the blood, it will say you have a Staph aureus, and then it will say if you have the resistance genes that make it MRSA. So it could be very helpful with these resistance genes. And overall, it's very good sensitivity, very good specificity. And this is what it looks like. It looks like a little toaster, and you put in your sample, and you put in some fluid, just some normal saline, and then you wait about an hour, and it will ding, and then we'll give you an answer. So these are the kind of things that are on the GI pathogen panel.
Yeah, so this is pretty extensive. So when it comes to bacteria, all the bacteria we were kind of talking about,
Yeah.
it has all the targeted PCRs, DNA, RNA set in there. And then for entero, E. coli, invasive or pathogenic, they have all those targets set. Then for parasite, they have the most common crypto, cyclospora, and Amoeba, Giardia set. And then for viruses, they have all those viruses that we care about that causes diarrhea. So it's very helpful because preset PCR that is able to probe that stool.
So it'll basically have a list of all these things and then say yes or no next to it, or a plus or a minus of what it found. So you can see how this can be very helpful if someone's been having diarrhea, and then you're able to identify it very quickly. And then the most commonly detected organisms, and you can see these are things that we see frequently.
And I do want to, next slide, please, if you could go back. So I do want to share one, something to be careful with BioFire. So you all see how there's C. diff on the BioFire panel. So one thing that we found was that BioFire was overcalling C. diff infections because usually when you have toxigenic C. diff, it's caused by toxin B. But when you have BioFire, it's screening for both toxin A and toxin B. So basically, it's overcalling non-pathogenic C. diff as pathogenic. So a lot of people, and then of course, now we do two-step testing for C. diff. So we don't immediately go for PCR for C. diff. We do the GDH and the toxin A and B, and then we do PCR if needed. So a lot of places have gone, if they're using BioFire, got rid of the C. diff test and they hide it. So you have to separately order the C. diff if you want it, because the BioFire was overcalling C. diff infection. So something important to know.
Yeah, and that overcalling can be a big problem if it's
Yes.
because it will take a little bit of DNA and then replicate it. And so it's hard to know, sometimes because sometimes you'll have a couple things that are positive, and then the question is, which one is clinically relevant, which one's causing a problem.
And the thing that worrisome here is it was testing for toxin A C. diff, which doesn't cause pathogenic C. diff. So it was picking up all the toxin A. So that was also a problem.
So then who should be tested? So individuals at high risk of spreading disease to others. So like investigation of outbreaks, and then patients with dysentery, diarrhea with fever, abdominal pain, signs of sepsis, moderate to severe disease, symptoms lasting more than 7 days, or immunocompromised. So these are kind of the same kind of patient criteria that we were talking about before, and patients that you want to make sure that you get a good diagnosis. And then a little bit more on the of when to test. So for acute gastroenteritis, so community-acquired diarrhea greater than 3 loose or watery stools a day for less than 14 days, and then at least one of the following. So severe illness, inflammatory diarrhea, high-risk host, public health concerns. So if there's anything, essentially the population where you want to get an answer very quickly. So, if someone is having just diarrhea, like we are saying, most of the time it goes away on its own, but if it doesn't go away, and they have one of these issues, then it's something that you want to identify quickly and get it taken care of.
And then also caveat, so just like hiding the C. diff test on BioFire, contraindications for GI pathogen panel is also, if a patient has been in the hospital for more than 72 hours, you shouldn't be doing GI pathogen panel. They're newly starting a diarrhea in the hospital. They would have presented with, they're just not now getting salmonella in the hospital. So usually they say not to use GI pathogen panel after 72 hours if a patient is in the hospital. And then also, in our system, we have like good workflow flow chart. If somebody has been getting laxatives in the past 48 hours, really, we should not be using a PCR test, expensive test. It's because they got laxative and that's why they're having diarrhea. So that's really important to remember as well.
So you don't want to, like, if you hear a patient has one bad diarrhea, you don't want to be jumping to multiplex PCR. And the benefits, reduce antibiotic use, reduce time to antimicrobial therapy. So it's being able to identify and diagnose quickly and get them on the right antibiotics. Lead to more targeted therapy, so they don't have to kind of give blanket like antibiotics to cover so broadly because you don't know what it is. And then reduce the downstream procedures like endoscopies or abdominal imaging. If you can get it identified, then they can reduce the procedures. And
that's really important because I was reading some studies prior to all of this when patients were having diarrhea and they couldn't figure it out on stool culture, then everybody started thinking patients have like Crohn's, ulcerative colitis. They thought other reasons that they're not diagnosing. So patients were getting endoscopies, abdominal imaging. That was really causing downstream, money and unnecessary So now rapidly, now you have an answer. It actually eliminates cost and unnecessary procedures as well.
And then drawbacks. So some of these we've talked about a little bit, and the first one here is significance of identified organisms may not be clear. So sometimes you'll identify something and you'll say, how important is this? And it's kind of unclear. And then as a result, they can detect organisms that are not causing a problem, that it's just that person's flora. And then increased detection of mixed infections. So identifying multiple things, and then you have to say which one's important, or are they all important? and sometimes it's not so clear. All right.
That's our last slide. So diarrheal illness, bacterial, viral, and parasitic. Most of the time, I would say in summary, if they're doing okay, you don't need any testing, supportive care. If somebody's traveling somewhere, I think it's really important to give them guidance.
Mhm.
And then, Imodium and azithromycin, adult taking that. And I think there is a place for molecular testing because on certain population, because it's fast, accurate, and it has downstream effect. Any other things that we should highlight?
Yeah, I think it's important to kind of think of when to test and when not to test. And that's one of the things our microbiology lab director kind of tries to instill in us is, that the test can sometimes be not indicated for all situations. And if you get a positive, it's important. So when to test and when not to test is I think one of the main things to kind of think about for these patients. Because the urge is to just test them and get an answer right
Yeah.
away, right? Yeah.
It's still costly, so I think
Mhm.
using it on the right patients, high risk, immunocompromised, persistent diarrhea is very helpful. Um, any other questions you all have on this topic?
All right, so if anyone thinks of any questions or that it comes to you later, please just send us an email. And then, we're always available for any questions also. So if you can call anytime with the hospitals that we work with, just give us a call and we'll see if we can help figure it out with you.
Thank you so much.
All
Have a
right, thank you,
wonderful day.
everybody.